tonight's talk. The topic will be rectal cancer, actually organ preservation in rectal cancer, which is a highlight and very important topic because we are experiencing a kind of changing in practice. We have already heard the results from the US OPERA trial with the good results from the memorial. We have already heard the exciting results from the European OPERA trial. It's my big pleasure to introduce to you Professor Gérard, which was not only the lead of the OPERA trial, but he has led a lot of trials in rectal cancer. He's a big expert in GI radiotherapy and brachytherapy, and he's actually the Papillon man. And encore une fois, bonsoir professeur, merci beaucoup d'être parmi nous ce soir. C'est un grand plaisir de vous avoir là. Et on est tous excités d'apprendre ce qui va venir après OPERA. Je vois aussi là dans l'audience, on est un groupe de plusieurs médecins. On s'occupe du tumeur digestif. Il y a des oncologues, des chirurgiens, des gastroentérologues. Je vois qu'il y a aussi dans l'audience virtuelle des collègues du dessin. Oui. Très bien. Donc je vous laisse la parole. Merci beaucoup.
I can start my talk and I will say that I will present the TRESOR study, which is mainly Papillon brachytherapy boost for rectal preservation. I will say a few words of the past, present, and I will end with this TRESOR study. So this is my disclosure. I have interest in contact therapy for more than 50 years, unfortunately now. I will start with what is contact therapy, what we call the past. It was pioneered by my mentor Papillon that you see here doing a rectoscopy. He was using this Philips machine here, and with this machine, in 4 fractions, he was able to achieve TCR in 80% cases. My first publication was in 1971 with him. It was contact therapy for this limbus tumor. And we had, as you see, 19 out of 20 local control. This is a good illustration of what is contact therapy. Very small field, very accurate targeting, no toxicity, and good efficacy. But now this Philips machine does not exist anymore, and I had the chance in the 2011 to find this engineer in England, and we made a new machine called Papillon 50. It was made in England, and now it is also performed in Clermont-Ferrand by the company Clarat. Both companies are working together to produce this contact X-ray machine. This is a machine. You can have applicator for skin tumors and eyelid tumors. You can do with this applicator breast IORT in 1 minute, but of course, you are interested in the use of contact therapy, Papillon machine, for mainly distal and mid-rectal tumor, always accessible with the finger. The patient is in the chest position. We introduce an applicator of 3 centimeter, eye-guided, high precision. Then we introduce the X-ray tube, and we deliver 30 gray in 2 minutes. The dose is inhomogeneous, high in the tumor, very low in the organoids. We treat mainly polypoid tumor like this one, and we achieve 80% of the cases clinical complete response. This was designed by a physicist, Anna, who showed that when you treat a tumor 35 gray, 30 gray, 25 gray, every time you give a dose, as it is inhomogeneous, the integral dose is around 12 gray. And when you do 3 times 12 gray, it is like an equivalent of 92 in 2 gray per fraction equivalent. And then you add chemoradiotherapy. So it is very high dose in a very small volume, highly targeted. And this is why contact is a unique technique. Very small volume, 3 to 5 cc's, very high dose, high precision, simple and safe, of course, needs some clinical practice. In France, there is 3 machines, and since 2 days is the 4th machine in Gustave Roussy. The 3 machines in the south of France were able to treat 74 patients, and the 4 years result, combining contact therapy and chemoradiotherapy, was 84%, and of course, It was in selected early T2, T3 rectal, and we call that a planned organ preservation because we can achieve a high rate of local control. This is our example. You see this tumor, T3B, T3A, and local control and good bowel function. I had the chance to collaborate some 30 years ago with a radiotherapist in England, Professor Smith, who was able to design the Papillon suite, exclusively dedicated to contact therapy. He treated more than 2,000 patients and he got many British medical awards for his achievement in rectal cancer with contact therapy. I wrote a paper in the Lancet in 2003, radiotherapy alone, T1 and 0, 80% control, combined endocavitary and external beam in T2, 80%, but of course at that time nobody believed. It's why we had to convince people with more science. And the science came from the OPERA trial. I will go rapidly through this trial. We all agree that for rectal cancer, TME is a standard of surgery, but more and more organ preservation is increasingly reported and of interest. There is many randomized trials closed with organ preservation at endpoint, and there is, I will see, some ongoing randomized trials. But the world reference is Angelita Bergama, the surgeon in São Paulo. And in her pivotal paper, she achieved 47% of organ preservation during this period of time with what she called extended radiochemotherapy treatment. The OPERA trial is very simple. It tests the hypothesis that if you add a boost of contact to the Haber-Gamma regimen, you will increase safely the organ preservation. It was presently published in the Lancet, and you will see that overall the result is close to 80%. Inclusion criteria, you know this trial is full operable patient with mainly small tumor. The standard arm is the Haber-Gamma, 45 gray 5 weeks with chemotherapy and the boost of external beam 9 gray, and the experimental, the same 45 gray and the boost with contact. When the tumor was less than 3 centimeters, it was contact first, followed by the chemo. And on week 14 or 2024, tumor assessment, partial response, TME, complete response, watch and wait. The response assessment is a very important point, and I like to make it with the digital examination, the bioprobe of the surgeon Lars Palman in Uppsala, with my special rectoscope, which is 2.5 centimeter in diameter to assess the tumor. I start with a small digital examination, then I do the rectoscopy, I can see the response of the tumor, and I make a second finger examination. At that time, I can see all these things and have a very accurate feeling of the situation. It can be a whitish scar, which is not very frequent, mostly when the tumor is very small. Most of the days we have some early matters. We can have also early matters. A small ulcer, some 2-4 weeks after the end of treatment. We can have fibrosis. We can have a more deep ulcer later, 3-6 months, or some fibrosis, osteomyelitis nodule. All these needs clinical experience. Of course, we like the MRI. We call TRG1 complete response, TRG2 good response with only mainly fibrosis, and all the rest is partial response. A tumor or tumor, clinical response, and TRG1, no more tumor. Most frequently, we have some fibrosis, and we can find this, what I call black crescent on the MRI, which is a fibrosis of the rectal wall. And sometimes we have also some fibrosis, but when you do the diffusion imaging, we have some restriction, and this is often a sign of persisting evolutive disease. OPERA trial was 3 centers in France, 1 center in Switzerland, in Genolier, and 4 centers in UK. We put 141 patients. The median follow-up time was 38 months, 69 age median, more male, more T2, more N0, and mainly distal tumor. Well balanced between both arms, A and B. B is contact therapy, A is Haber-Gamma. And when the tumor was less than 3 centimeters, also 29-32, good balance of all the parameters. The response at week 14 or 24 with palpation, endoscopy, and MRI in Haber-Gamma regimen 64% with the contact 92, significant, and when the tumor was less than 3 centimeters, 97%. Out of the 113 patients who were in complete response and went on watch and wait, in the abergamma arm, there was 23 local relapse or regrowth, and 15 in the patient with contact. It was a bit delayed and a bit less with the contact therapy. And combining more clinical complete response and a fewer local relapse rate, the primary endpoint, which was rectal preservation at 3 years, was 59% versus 81%, quite highly significant. When we look at the patient with tumor less than 3 centimeters, it was 63 up to 97%. And what is the interest of starting with contact therapy? This is the rectoscope I am using, which is 2.5 centimeters. It is the patient of 47 years. It was in 2017. Patient come with this tumor, which was a T2N0. It got 30 gray in 2 minutes. And 2 weeks later, the tumor has already gone with a response of 90%, ablative dose. And then, of course, we made a smaller field and 10 gray in the large field, 3 centimeters and 20 gray. And 2 weeks later, there was a complete response, and then 45 patients alive 5 years ago. The merit of starting with contact is accurate tumor targeting. You see the tumor very well. You give the high dose, no dose to the organ at risk, and most of all, the evaluation is quite rapid at day 28, 4 weeks later, and complete response in most of the cases. This is good for the patient anxiety and for our anxiety. Of course, there is some toxicity. The second, we are afraid of doing TME after such a high dose of radiotherapy. We have 39 patients with TME, second surgery in 7 out of 39, R1 resection in 4, no deaths, median hospital stay 9 days, and in fact, the message is you can operate with TME surgery after such a dose with really no increased toxicity. The general oral toxicity was quite good, with no grade 4 and 4. Bowel function was measured with large patient in patient with preserving rectum, and you see that the large function was less than 30 in 39 and 83 means good or excellent bowel function. The most important side effect of the contact boost is that you have some blood in the stool, 63% versus 12%. Most of the time, grade 1 or 2, and it is mainly due to telangiectasia, and as you see, this bleeding stopped after 3 years. When I presented this data at the ASCO meeting, there was 2 other candidates for organ preservation, the WW2H, Danish with 61%, 2-year TME-free, OPERA with 53 in New York, and the OPERA with 80% at 3 years. Recently, in February, we update our result at 4 years, and you see that at 4 years, on the overall patient, there is exactly the same result, which is maintained, 59% abergamma, and with the boost, 82% out of 141 patients. The conclusion was this trial was given by the surgeon from Eindhoven, Harm, that you may know. He said in his editorial, OPERA, the first study with a high level of evidence for rectal preservation. Organ preservation is a treatment goal. You can plan your treatment preservation. It is not anymore a lottery. Contribution of contact is apparent, and this could lead to a change of practice. In fact, this is not really new. I made the same randomized trial in 96. I call it the Lyon 96, published in the JCO. It was operable patient, preoperative, external beam alone versus external beam with the same 90-grade boost, CCR from 2% to 30%, think of preservation moved to 60, and already at that time, 25% of organ preservation. This randomized trial was updated at 10 years, and there was no difference. It was maintained, and this gave the opportunity for the National Health Authority in France to recognize contact therapy for operable patients. In England, they say the same thing, but they restrict it mainly to frail elderly patients. I don't see the reason to restrict to inoperable patients. There is many unknown. What are the biomarkers? I like the immunoscore. The response assessment is a very difficult thing, and it takes time. I like watch, and wait. Don't rush too much before taking a decision to do a TRESOR surgery. What is the best radiotherapy? There is different kind of radiotherapy. The role of local excision for me is very important, and I think that going to the Rektum 12 and the Star Trek trial will have more information. Also, the TRESOR strategy, like in New York. We made the evaluation of the MRI. We had some work like this, and we analyzed 33 MRI. We had some experts, and at the end, it was the end of this time we made the final comment. This was the key MRI for the screening, and you see that only in 4 cases, the 4 experts were in disagreement with the screening of baseline in the OPERA trial. That means that in most of the cases, they agree with the baseline characteristic and classification of the MRI. And when they were not in agreement, it was only that they moved T2 for T1 in 2 cases, and here also from T3A that they moved to T2P. So this is T3, which was in fact T2, and this is T2, which was in fact T1. In 4 cases, there was downgrading and staging of the tumor. We made immunoscore, and here in immunoscore, when it is high, you have the impression that the local control and is much better than when the immunoscore from Pages is low. So if I want to summarize what is the place of contact therapy in rectal cancer, I would like to use this ESMO classification that I find quite good. There is a very early cases, CT1, SM1, and 0, local excision. And the ESMO guidelines say adverse histopathology, go to TRESOR standard. In fact, this is a patient with a pejorative factor SM2, and we can give contact therapy and combine with 45 gray or 5x5. And we made a publication with my British colleague, 193 patients, who had local excision, a pejorative feature of the pathology, and instead of TME, we made an adjuvant contact therapy and some kind of external beam therapy. And you see that at 3 years, the local relapse is 5% and 7%, was published in the Green Journal in 2021. And the distant metastasis, 6%, 11% out of this patient with the 5 years follow-up. So for the very early tumor, I will not advise to do TRESOR surgery when you have an adverse histopathology, but I would advise to do contact adjuvant with some kind of external beam concomitant. Then for the early good, it is the one we have included in the OPERA trial. We have the T2, the T3AB, and these patients, when, especially if they are less than 3 centimeters, are fully, I think, in the strategy of organ preservation. And if you can start with contact, followed by CAP50, I think it is a good way to do that. Then we have these, what we call locally advanced, which are probably the most frequent. What to do with these patients? For the ugly one, very advanced, I think there is no chance of organ preservation. But for the other one, I think probably TRESOR is an option. I made a trial in 2012, which was the after 12 trial comparing CAPE45 with CAPOX50. In this group, there was increase of dose and increase of chemotherapy. There was increase of toxicity. There was more PCR in this group than in this one. But I knew at the same time there was the STAR trial from Carlo Aschele in Italy, exactly the same trial, 700 patients, the same dose of radiotherapy and only adding oxaliplatin. And by adding oxaliplatin, they increased the toxicity from 7 to 24%, and they did not change anything to the sterilization rate. That means that if I am back to the CAPOX, the toxicity here is mainly due to the oxaliplatin, and the increased sterilization is mainly due to the dose increase. And this is the same in most of these other randomized trials. There was no difference in disease. Maybe the small rectums, great improvement with the capox 50. And now in France, the reference is not capox, it is capecitabine and 50 grade. But of course, we all know that the rectum is very low and deep in the posterior pelvis. You see, this is S2. All the rectum is below S2. And all the recurrent, this was well shown by the Dutch trial, are below the S2. So if you give 50 gray, you restrict your upper limit volume to S2, and then you can boost 5 gray more to the gray to the club. We made also a NAT trial that we published recently. It was following the Accord 12, and for the patient more than 75 years, we compare K50 with 5x5 in order to try to reduce the toxicity. And in fact, what we showed, it is not a surprise that 5x5 is 3 times less efficient than K52 to sterilize, 17%, 6%. But the overall survival was not different and a bit better with 5x5. This trial was stopped only with 100 patients, but the message is maybe 5x5 is a good option when you are in elderly patients, but if you want to sterilize, it's better to do K50 than 5x5. Then we have an important trial in France done by Thierry Conroy, the PRODIGE 23, where they increased the total neoadjuvant treatment with 6 FOLFIRINOX. They increased the sterilization rate, but did not change anything to the overall survival rate. And they treat mainly and a lot of high rectal tumor. And my message is that in the EORTC 2092-1, by subgroup analysis, it was shown that the effect on disease-free survival of adjuvant therapy is mainly due in the tumor of the upper rectum. It is in the upper rectum, and my question, I am not absolutely sure, but maybe for lower tumor of the rectum, in the distal part of middle rectum, chemotherapy is not as efficient than in the upper rectum. And I remember that we treat only distal tumor. And this is the PRODIGE 23. One of the reasons for the importance in favor of the disease-free survival for the PRODIGE is that there is more deaths, toxic deaths in the experimental arm. It is why here you have a sharp drop of the survival curve, but when you look at the overall survival, it makes no difference. But most importantly, to look at the organ preservation and looking at the chemotherapy, the GRECA-12 trial is important. It was a trial by Eric Cuillet, surgeon in Bordeaux, taking T2 early T3 less than 4 centimeters, K50 to everybody, and randomization, local excision versus TME. There was only 38% of local preservation, but the most important that when you do TME or local excision, the cancer-specific death is only 7%, and there is no difference. That means that doing a local excision and doing the preservation of the rectum is not detrimental for the survival and the risk of metastasis. Then at the present time, there is a GRECA-12 again from Eric Cuillet and others in France. They include the same T2, T3 less than 4. They give K50, or they give 4 FOLFIRINOX, 4 courses, then K50. And they try to increase the organ preservation rate at 1 year from 40% to 60%. This trial, when I saw it, I said, well, I'd like the light treatment of 3 courses of contact therapy, and here we have 3 months of FOLFIRINOX, which is quite strong. Nevertheless, they include the patient, mainly in Bordeaux and so on. And at the present time, there is 213 patients in this GRECA, which is finished. The results are not yet known, but from Véronique Vendredi, we can know that out of these patients, at blinded, at 1 year, there is 67% of organ preservation. We don't know there is difference. Overall survival is very good. Local recurrence is 7% only, and distant metastasis. The tolerance is acceptable. This is very important. We can give 4 courses of FOLFIRINOX. The result will be known at ESMO. So when I look at this body with 6-4 and data with 4 PG only, I must say that from a point of view of toxicity, I will prefer to make this 4 courses. So if I go back to my stratification, T1, local excision, adjuvant, if adverse etiology. T2, T3, small tumor less than 3 centimeters, start with contact and with contact therapy and capacity. But for the ugly, no chance of organ preservation. But for this one, maybe here by combining total neoadjuvant treatment with FOLFIRINOX, contact therapy and radiotherapy, we can achieve something. It's why in France, now we have designed the TRESOR trial. It is designed by the Gustave Roussy group with Durand Labruni and Eric Dutch. We include only patients of 75 years because TRESOR is with FOLFIRINOX and FOLFIRINOX cannot be given above 75 years. We treat T2 with N1, T3BC, 4 to 6 centimeters, less than 60% centimeter, and of course we don't include T4 or big N2 or big vascular invasion. This is the standard treatment. We give FOLFIRINOX, K50, and we make the evaluation. And in the experimental arm, we give the same kind of chemotherapy neoadjuvant, and we give the contact therapy during the second, during the third, fourth, and just before radiochemotherapy. We include T3BC 3.5 centimeters, less than 6 centimeters, less than 2/3 circumference, and the one less than 35. And the phase 3 survival 2 years TB3 is 45 to 65. This is not working, but it should start in probably October, November this year. We can also have 6 courses. I prefer the 4 courses we can discuss. This is some example. We are nearly 3 years ago. It is in Macon with Dr. Barbet, a big tumors, and we start with FOLFIRINOX. After FOLFIRINOX, good shrinkage, contact, CAP50, local control 3 years later. Another patient I saw in Nice, a tumor of the posterior part of the rectum. I have to treat the patient in the gynecological position. It was very difficult to assess with the contact in the mid-chest position. Small ulcer at the end, and now 2 years later, this patient is all right. Another case coming from Avignon, tumor, 12, a T3, 6 courses of FOLFIRINOX, good response, CAP50, good response, small residual tumor. I saw the patient in August, you see, 8 months after the start of treatment. This was the residual tumor. This is 2.5 centimeters. I gave 30 gray, and complete response, and good tolerance. We have treated 14 patients in the, I call TRESOR phase 2 trial. Patient size tumor was 4 centimeters, 60 years, T2 and 1-4, T3 mainly thin, 4 FOLFIRINOX 7 cases, more than 4 in 7, contact during FOLFIRINOX 11, contact after FOLFIRINOX and radiochemotherapy 3 cases. And so far at 1 year, we have 12 patients out of 14 with organ preservation. The last score is good in all the patients where we can make this measurement, and the toxicity is quite acceptable. So, I will organize in November of this year a special meeting on preservation of the rectum. We will have all the randomized trials in the world with this endpoint, organ preservation as endpoint, coming from Germany, from Brazil, from New York, and so on, Birmingham. And I think that in this trial, we will improve our knowledge of what we can do for organ preservation. So, a brief word of conclusion. Adenocarcinoma of the rectum is a radioresistant tumor. TME is a studied, but organ preservation has a growing interest. We must select the patient, and when we have early tumor from palpation, scope, and imaging, and if we can start with contact first, I think we can achieve 80% at least organ preservation safely with a good bowel preservation, and to increase further this possibility of organ preservation, I think that to participate to the TRESOR trial would be a good idea. Well, thank you for your attention, and I'm open for all your questions, of course.
Merci beaucoup, Professor. Thank you very much. Very exhausting presentation. But I didn't understand, Professor. So you already start with inclusion in the patient in the TRESOR? No,
in TRESOR, the trial is not yet open.
It's not yet open, okay.
It's not yet open. It is the primary investigator is Durand Labruni, and he will be in Vienna, where we will discuss with him the trial, and probably we'll start the trial in October or November. They just received the contact machine, and I think this trial is having a quite large interest in France. But of course, if any other centers from France or Switzerland or any country want to participate, if you are in touch with Gustave Roussy and Durand Labruni, he will probably try to include all the goodwill in this trial.
So the patient you presented was treated like it would be in TRESOR, but outside the protocol, right?
At the present time in France, the FOLFIRINOX neoadjuvant treatment is getting very popular because, as I show you, we have this PRODIGE trial from Thierry Conroy, and we have this GRECAR 2 and GRECAR 12 trial. So in many cases now, when a patient with a T3 tumor is seen at baseline, they do the workup, there is no metastasis, and they start with FOLFIRINOX. And this morning, I saw a patient from Avignon. He had 5 courses of FOLFIRINOX, and the tumor was nearly in complete response. So at that time, the people who are now aware of the possibility of doing a conservative plan strategy, say if there is already a very good response with only FOLFIRINOX, maybe if we have contact therapy and CAP50, we will achieve such a rate of 80% organ preservation. It is why what I call this pre-TRESOR study, which is not at all randomized, it is just patients seen in the MDT meeting. They say, why not try to do contact therapy, and why not try to have organ preservation? It is why we are able to accrue this kind of patient that I call pre-TRESOR, but it is not in the trial. Only the phase 1-2 trial to see the efficacy and the tolerance. And the message, as I show you, is that the tolerance is good. I will say, to my surprise, this patient was 66 years. He had 4 cases, 4 cycles of FOLFIRINOX, and he was in good condition, and the tumor has a response of more than 80%.
Okay, thank you very much for the interesting presentation. We are here a little bit more German and Anglo-Saxon influenced, so we normally start with the long, in the nasty tumors, in the bigger tumors, T3, T4 even. Sometimes we start with the long-term radiochemotherapy, and then we do a systemic therapy with K-box as in the OPERA trial, and then one can also think about organ preservation if you have a full response, and even do contact radiotherapy at the end if you want to consolidate. That's then this French concept, as you are now doing in the TRESOR trial, transferred to a more, let's say, German or Anglo-Saxon approach. I do have a specific question regarding the follow-up. This is really crucial to, I mean, these lesions, you know, is there any guidance how you go forward? You just said once, if you have a complete remission, don't go rush in and operate. But how is this now actually done? How do you follow up, and how do you decide I mean, there, of course, you do in the interdisciplinary discussion, you do it, but still, is there some clear guidance how to follow up these responses and when to intervene? Can you perhaps give there some help?
Well, I understand there is 2 points in the message I understood. First, and I fully agree, that according to the German AOCARO trial, you prefer, when you do a total neoadjuvant treatment, to start with radiochemotherapy and give the chemotherapy as a consolidation chemotherapy. In France, as you see, we are more inclined to do with the chemo because we have the PRODIGE trial, and the Emmanuel Focas will be in Nice next November to propose this trial and to see what are the differences. And I have no clear answer to should we start with chemoradiotherapy or should we start with the neoadjuvant induction chemotherapy. For the follow-up, which is absolutely crucial, for me, I do myself the rectoscopy. When I have a doubt of my examination, I ask my colleagues, the gastroenterologists, to do a rectosigmoidoscopy, and we are together doing the digital examination and the endoscopy. And a digital examination and a rectoscopy with a rigid rectoscope can be done every 2 weeks. So anytime you have a doubt on is it a recurrent, it is a regrowth, is it an ulceration, it is a toxicity, well, you can see the patient every 2 weeks. And the MRI, of course, you don't do every 2 weeks, but you can do the MRI every 2 or 3 months, depending on your impression clinically. For me, the palpation and the vision, the watch, is the key parameter to evaluate the response of the tumor. And of course, we should not have a too long interval between two examinations, because from 1 week to 2 weeks later, you can see quite a big difference. And looking at this difference makes your evaluation more reliable. And I will say that more you wait, more you will find that you are in a near clinical complete response, will become a clinical complete response. And this is a message also from Abergama. Don't rush to decide for a TME. And if you decide to a TME after 2, 3, 4 months of follow-up, I will say that it will be good to be sure that it is a recurrence and that you have a preoperative biopsy on a radial tumor which shows adenocarcinoma. I will be quite reluctant to do a TME only on an MRI if the palpation is normal, if the endoscopy shows a quite normal mucosa or with a small ulcer, and if the biopsy is negative. I think that if you do a TME in such situation, the risk of having a YPT0 operative specimen is quite high. And in the OPERA trial, we have some patient who was operated with TME and the head was PT0.
Can you know, do you know the percentage of still positive tumors who received TME in the OPERA trial? That would be quite crucial, because then you would have phasely done the operation or phasely judged that it is necessary. How big is the percentage of wrongly operated patients in the OPERA trial?
I am not sure I understood perfectly the question. In the OPERA trial, we had 39 TME. Most of these TME were during the first 2 years. There was twice more TME in the arm without contact, and most of this TME was done for local regrowth or partial response.
And how many were positive? I mean, how many?
I will say that 85% of the pathological specimens were positive.
Okay.
It is very unusual that we had a a PT0.
So in 15%, the tumor was operated despite the fact there was no tumor left. 15, 1-5.
Yes, out of the patient who got TME, something like 15%, I could check with my figure, they are not very far from me, but out of these 39 patients, I will say that 15 were in fact PT0, and it was a regret to have made a surgery. And one of my patients that I know quite well had a tumor, had a nearly complete transplant. Then the surgeon was a bit afraid, and he made a local excision. And on the local excision, it was YPT2 with small residual cancer cell. So they decided to make a TME surgery, and the operative specimen, they found no more tumor. So it is true that to select the patient for TME is a very, very subtle clinical approach, and you need the triad of palpation, scoping, imaging, and my advice, which is the same advice at Angelita Borgana, is don't rush to make TME. You can wait 1 month more, and maybe by waiting 1 month more, you'll be quite more quite that it is a clinical complete transplant and does not need TME, with the risk of making TME for a YPT0.
Thank you very much. Thank you.
One question from myself. Very, very easy. The local radiotherapy, the Papillon radiotherapy that you use is not widely available yet. So if I understood you correctly, other centers, how do they do the boost? Is this just stereotactical boost, or how do they do it physically?
If you have no contact, there is an alternative. It is the high dose rate brachytherapy with iridium, which was pioneered by Wong in Montreal. I think the technique is a bit more toxic, a bit less, as not efficient, but it is a way to boost locally in the lumen the dose. And if you have no access to any intracavitary irradiation, of course, I have a bias. I think that contact therapy has the best cost-benefit ratio because low toxicity and high dose to the tumor. But if you have no contact therapy and no HDR, the only way is to do external beam dose escalation with some stereotactic irradiation, like, for example, the WW2 trial of Janssen in Denmark or the Aphrodite trial in UK. And all these trials will be presented in November in Nice at the UK meeting. Yeah? But I think that the future, I hope, is that these two companies in France and in England, Ariane and Clerad, will be able to produce robust contact therapy machine Papillon. I understand that their business plan is to produce 10 machines in 2023 and then 20 machines per year in 2024. And I understand that there is some more discussion with some German company who are able to make the same X-ray tube. And of course, it will be good to have this German industry going in the field of contact therapy.
Okay, thank you again. Thank you very much for this excellent presentation and interesting talk. And maybe we'll see you soon at the Estro maybe. And thank you everybody for listening.
Thank you.
Thank you.
Thank you, bye-bye.